Okay, so the first one, you're an FY2 doctor in an outpatient medicine clinic. The patient's Joanna Lumley. She's a 27-year-old lady who's been referred by the GP. She's planned for an upper GI endoscopy. She was diagnosed with celiac disease after a positive tissue transglutaminase antibody result. Take a focus history, explain endoscopy to the patient, and address their concerns. So it says she was diagnosed with celiac on the basis of an antibody test. So it's kind of more of a provisional diagnosis, right? So it's not a definitive diagnosis because she's not had her biopsy yet. So really, the patient here is already, celiac disease has already been mentioned. So she's aware that she might possibly have celiac disease. And, you've been asked to chat to her, to ask her permission to do an endoscopy and to find out if she's happy to go ahead with it. You're not taking like consent in this station. Consent will be taken on the day or maybe a few days prior to the procedure, usually by the nurse. They'll come in before their procedure. The nurse will re-explain the benefits and the risks and take the written consent. And then the patient will just like move into the waiting room for an hour or so and then have the procedure done. So this is just kind of introducing them to doing the procedure, getting the go ahead from them, that the verbal consent and that they're happy, and then you can book the appointment. So that's the idea behind this kind of station. So yeah, who would like to do this one? Who would like to role play with me this one?
I think I want to give it a try.
Okay, so yeah, so are you familiar with we've been using the GMC timer? So they've got 3 color codes. So the introduction is for the first 20 seconds, it will be a gray background. Then it will switch to a blue background. 20 seconds, it will switch to a blue background. And then after 4.5 minutes, it will switch to a green background. So the gray background is really where you should be doing the introduction. The blue background is for history taking. And then the green background is for management. So it's just a guide there so that when you're, because you're going to be focused on on the consultation. So you'll have this there in the background and then it'll just guide you there just to make sure that you're not kind of losing track of time. Does that make sense?
Yeah, sure.
So in the exam, you will have a 6-minute bell. So, do look out for the 6 minutes there because that's kind of a nice reminder just to kind of wrap up. And if you're still quite early on in the consultation, that's like a final reminder just that you need to get on to the management.
Oh,
all right. So is that okay if you'll be able to do that? And so we've got 8 minutes. Is that all right?
Yeah, sure.
So the patient's name is Joanna Lumley. She's 27. But yeah, by all means, ask it again in your consultation. Okay. Yeah. Start now, please.
Hello, Jonah. My name is Doctor. I'm one of the doctors in the department. I've been told to counsel you concerning a procedure following your diagnosis. Are you aware you've been diagnosed to have a celiac disease?
I am, yeah.
All right, awesome. And I'm going to take you through what it is and what the procedure is expected of you. Can we go ahead? Are you okay to go ahead?
I am, yeah.
All right. I want to ask a few questions. Have you been passing waters too?
Yes, I have. Yeah.
Oh, okay. Have you had any medication? Have you been on medication for it?
No, I've not. No.
Oh, okay. You've actually been diagnosed to have a celiac disease, and we have some investigation. We've got an investigation we want you to go ahead with, and we really think that's going to help us to manage you properly.
Right. Okay.
You want to begin by explaining the procedure with you and find out what you think about it, if you're okay to do it, and share with me if you have any questions and any concerns. Is that okay?
Yep, that sounds fine. Yeah.
Oh, okay. So having been diagnosed with celiac disease, we need to do a procedure, and that is basically having a tube with a microscope attached to the tip, and we're going to pass it through your mouth into your intestine, just to see just to confirm and see you've actually got this disease in question. So the tube is flexible, and when we pass it through your mouth, it's going to go down slowly. It's going to be done on the sort of on the telly, on the monitor. We could easily see what it is like when we get down into your intestine, and we could make our assessment, and we could manage you properly following that. I want to ask if you've so what we call that procedure is endoscopy. I want to ask if you've heard have you heard about endoscopy before? Have you read about it?
I've got like a a basic idea of like a camera that's put in to see inside the body.
Oh, okay. How have you ever had it done before? Is this your first time?
First time, yeah, it would be my first time.
Oh, okay. So basically, I want to say you don't need to worry. We might give you some anesthesia, which could help you to relax, so it goes in smoothly, and also you will have less complication from it. So we're gonna be able to carry out this procedure smoothly with minimal complications to your gut. Do you have any questions? Do you have any concerns you want to raise with me?
Yes, I do. Yeah. So you mentioned anesthesia. Am I going to be asleep?
You're not going to be asleep. It's just something to help you relax. So this flexible tube can go in slowly with less resistance into your intestine.
Oh, I see. Okay. So it will just kind of relax me a little bit, make me a bit drowsy.
That's right.
Okay.
Do you think is okay with you? Do you think it's something you want to try?
Well, I mean, they did the test, and the blood test, and they told me that I've got celiac. So I mean, is it really necessary that we have this as well?
I think it's necessary, because this is going to help us further to know how to manage you properly and care for your health, and also help us arrive at a definitive diagnosis, and do the proper management for that. I think if you're okay with it, we could do it, so we could find out exactly and be very sure we've got you properly diagnosed.
2 minutes remaining.
Have the proper management for you as well. Do you have any further questions you want to share with me? Have you got any other concerns?
No. So I think that makes sense. So it's kind of you said it's not definitive. This is to make it definitive. Is that right?
That's right.
Okay.
Okay.
Right.
I'm
And,
happy. Okay. Can I hear from you?
Yeah,
please?
just another question. So is there anything beforehand? Is there any preparation I need to do before, or can I just go in?
Yeah. I was gonna tell you that.
Sure.
So in this procedure, we're gonna ask you to fast, and it's not gonna be a lengthy fast. Probably about 6 hours before this procedure, and this is basically to allow the guts, the intestine emptied, so we have less resistance, and it will also give us a clear vision of what your intestine exactly looks like when we see it on the monitor while we're carrying out this procedure.
Right. Okay. And I heard that you might be taking a sample or something. Is that right?
Yeah, that is absolutely right. So in the course of this procedure, we might need to take samples from you, and there might be some bleeding, but we are prepared to control the bleeding so it doesn't go it doesn't get serious, and we have a team which is capable of managing this scenario properly.
Right. Okay.
All right. Thank you very much. For your time, and at this moment, I'm going to inform the team that you're ready
Move
for
on
it.
to the next station.
Yeah. If you want to just continue the last couple of sentences.
Yeah, I just said thank you very much for your time. I would like to inform the team that you are ready to go on with the procedure.
Right. Yeah. I think that should be fine. Yeah, I think we might as well go ahead with it. Yeah, why not?
All right. Thank you very much, John.
Thank you very much, Doctor.
Uh,
So how was that?
I was tensed, and it's my first time actually having this done.
Oh, that was really good for the first time then.
Yeah, it is.
So yeah, very nice. Time management is good. Got straight to the point really, which I think is quite refreshing actually. That we just get straight to the point. I think because at the end of the day, it's quite a negative exam, and so if you miss the key themes, then you'll be punished for that, as opposed to being rewarded for doing an excellent kind of thorough consultation. So you mentioned apart from it being your first time, how do you feel that went otherwise?
I think I haven't listened to some videos about PLAB 2 and how to go about the station. I tried to keep to time management, and the GMC time planner really helped, and I was interested in focusing on very relevant things of that is what I must do before the time elapsed. So I tried to be very brief with the grapes, and I also tried to ask a few questions concerning the history, and I went straight to explain and also get the patient's concerns and try to alleviate their fears and know if they've probably had a prior knowledge of this procedure, and also tell them what it is like and thank them for accepting and promise to inform the team that the patient has accepted and will be ready to go on with the procedure.
Right. Yeah, I think I agree with you. I think you definitely you touched on most of the key themes in the scenario. So I wrote a few notes. So at the beginning, right. So I did tell you my name and age, but I would say definitely, or name and date of birth. I would say definitely, do confirm those details before you start. So do remember the demographics. Just name and date of birth definitely is worth asking. Before we start, if I could just confirm your name and date of birth for me, please, and then you can just get straight into it. So it doesn't take too much time, but I think that's worth doing. Just to make sure you've got the right patient. Just for the purpose of the role play. So yeah, that was one thing, and then yeah, I think I do think when a patient enters a consultation, I think they should be afforded the opportunity at the beginning. Like GPs call it the golden minute at the beginning of the consultation to kind of if there's anything that they have on their chest that they want to express, so just kind of like give them that opportunity just to say anything they want to say at the beginning. They'll probably just take about 30 seconds, but there might be something that's on their mind that they want to address first before so definitely focus on what the patient's agenda and make sure it's patient centered. So just make sure you ask an open question at the beginning. I felt like it was a little bit. It felt like it was, the closed questions were too frequent at the beginning, and you should have, started with an open question, even if it was just "How are you?" or if it's, "Can you tell me about what's been going on so far?" Something along those lines. Let them get off their chest anything they want to, because at that point they might give you some really important clues, that you would need to pick up on that are important in the case, but you wouldn't know that if you didn't give them the opportunity to do that. Does that make sense? So I think it's it's good to give them the opportunity to help you, because at the end of the day, the actors in these role plays, they've been briefed. They're not going to be like real patients who blab on for ages and waste your time. They're going to be very to the point. So if they are going to volunteer information, it's probably because it's important. So it will be helpful to you. So definitely give them a chance to, instead of kind of going with closed questions, give them an open question so they can orientate you on what's important first, and then you can after you've addressed that, then you can move on to talking about the closed questions, because you mentioned the diarrhea and stuff. So instead of you mentioning diarrhea, it might be worth just asking her what's happened, and she can tell you what the important points are, the bloating and diarrhea, and if she's had weight loss or any other complications. That might that could potentially have been a good opportunity to get some important information that you might not have been aware of before. So that's one thing. And then so really, yeah, just demographics, open questions at the beginning. Yeah. So and then I would ask maybe a little bit, because I would say this is the first time we've met. So if you don't mind, before we get into the procedure, would it be okay if I asked you just a few questions just to get a bit of a background about yourself, and a few questions about medical conditions or any medications and things like that? Is that okay? And then just bang out the 2 or 3 important questions for 40 seconds or so, and then move on to the explanation. So, you know, things like, you know, past medical conditions, is she diabetic? Things like, you know, what were the symptoms that led her to see the doctor? Just from her own view, just a quick summary. So I would start off with that, the kind of the symptoms, and then I would go straight on to past medical history, drug history, and maybe, you know, ask about the diet, the social history. But you know, I wouldn't. I'd say diet's the only one really. Maybe smoking, but you know, otherwise, the other stuff you can take it or leave it. But definitely ask about diet, and then, you know, move on to you know, the explanation. It's worth fitting in a couple of 2 or 3 questions maximum. You know, important questions, because at the end of the day, if you want to know if they're going to go for an endoscopy, you want to know if they're on blood thinners. So drug history is relevant. If they're going to go for an endoscopy, you want to know if they're diabetic or hypertensive, because, you know, you're going to have to make adjustments in the procedure. Now, okay, obviously, a lot of these things will be on record, right? But I think it's worth doing that in the exam just to check. But yeah, and then so you moved on to the explanation. Explanation was good, yeah, and you did, you know, you did include the patient throughout, which I think was good. So you did involve the patient. I felt at the beginning not so much, but then in the second half definitely involved the patient a lot, and I thought that was good. Yeah, so explanation was fine. You mentioned microscope. I didn't quite understand that bit. I might have misheard you. When you talked about there being a microscope in the endoscope, did you say that? Or
yeah, but I actually meant to say a camera.
Right. Okay. Yeah. I thought that's what you meant. Yeah. Okay. That's fine. So, and then the anesthesia. Yeah. So, okay. Yeah. So local. So it's like a local anesthetic spray, isn't it? That they usually use, plus or minus a sedative. I would say conscious sedative to the patient, because when they think of sedative, they think they're going to go to sleep. So I would call it a conscious sedative. But obviously, you can just say anesthesia, and then the patient will probably ask you then if they'll be asleep. So just one thing. The risks. You mentioned bleeding. I remember you mentioning bleeding. Did you mention any other risks at all about the procedure in general?
No, I only talked about bleeding.
Okay. Yeah, I would put maybe a little bit more emphasis on, you know, allocate a little bit more time on the risks. You know, the risk of perforation, infection, and minor damage. I would definitely mention some of those from the start, because if she goes into the procedure, you know, on the day, and then the nurse who's taking her, you know, who she's getting the written consent from, she then you know, informs her that, you know, there is a risk of perforation, and then you know, if the patient's shocked by that, and she's, you know, angry that, you know, that wasn't explained to her before, and that she wouldn't have gone through with it if she'd known there was a risk of perforation, even though it's a very, very rare, 1 in 10,000. But then, you know, so it's worth getting those things in there. So definitely, I would, you know, just give them, you know, 2 or 3 of the potential risks. So perforation, 1 in 10,000 chance, very rare. Bleeding, 1 in 1,000 chance. And then risks of minor damage, which are usually easily treatable with surgery, and any kind of adverse drug reactions to the medication. Yeah, I think otherwise, yeah, that was about it really. I mean, what do you think about those points? Do you agree with those, or?
Yeah, I think I agree with it absolutely, because as an FY to doctor, my role is actually to clarify, know what the patient needs to know, and also tell it to them, because I think the GMC Good Medical Practice clearly state that you should give this information to patient. I must give this information to patients. So the risk, I should have said bleeding, the perforation, infection, and I also agree with you when you said I didn't take more history, which is very relevant. I should have also asked the patient, or especially the history of taking warfarin and as blood thinners. It could be a reason why they could end up with bleeding. And I should have also taken a past medical history if they've had maybe previous surgery, intestinal surgery. It could be a reason for perforation, or a reason for maybe the procedure not being, it could even be a contraindication for the procedure to go ahead if they've had previous abdominal intestinal surgeries or something. I should have also asked about the diet to make sure they have actually fasted and had not had something to eat before the procedure. And I also agree with you when you said I didn't give the patient time to express themselves. Initially, I should have started with an open question so I could get the clues and from the patient, so I could address those those are clues as well.
Yeah, I think I completely agree with you. Yeah. Yeah, I think, just as a bare minimum, just, blood thinners and past medical conditions, and what was it that led her to see the doctor initially. So, just as a bare minimum, I think those 3 questions. But yeah, I agree. And possibly diet, to find out if she's on a gluten-free diet or if she's not, because if she has started a gluten-free diet, she shouldn't, because she needs to be taking gluten for the procedure. So yeah, those are the kind of the main points. When it comes to patient safety, those kind of things about blood thinners, and we need to get into the habit of asking those. If you're going to be doing something to the patient, so that where there are complications involved, like bleeding and infection, it's important to be aware of, take a quick history from the patient firsthand. So definitely etch that kind of internalize that kind of habit of doing that, because it's important for safety. And obviously that a large component of this exam is assessing your safety. So definitely make sure you ingrain those things into as habits for when you're talking about procedures and things like that. That checking for blood thinners, checking if they're diabetic, checking if they're hypertensive, checking if they're a smoker, checking past medical history, if they had a heart attack recently, or any coronary events or anything else. And then the open questions, definitely I agree. Yeah, I think it's for your own benefit. I think you come into the station and there's so many things that you want to say at the beginning, but sometimes it's nice just to let the patient talk. You won't be penalized, because I think we unconsciously come into a station thinking the more we say, the more marks we'll get. It doesn't necessarily work like that. You're extracting information. So a large component is you extracting information. It's not just you delivering information. So make sure you have that balance right. Of data gathering and then your side of things, which in this case is explaining the procedure. Definitely then you'll, of course, you're going to be talking more, but with the data gathering, definitely she certainly at the beginning of the data gathering, she should be talking more. Thank you very much for volunteering for that one. Let's have a look at some of these notes. So grip. So this is just a suggested framework. These are just training wheels. It probably is better if you have your if it feels natural. If it feels like you're following a structure too much, then the examiner will be able to tell. So yeah, to try and keep it natural, but these are just a suggestion. So I understand the doctor has previously spoken to you and that a possible diagnosis of celiac disease was mentioned. Is that correct? And then I've been asked to have a chat with you about possibly doing another investigation to test for celiac. Would that be okay with you? Ending with an open question. So you've got your bits in there. You've got your your plan, what your plan is, and you've orientated the situation. And then you can start with your open question. Could you first give me a bit more of a background about what's been going on? So that's just a suggestion for your first opening question, and then she can tell you about the symptoms that she was having, and then the test that she's had, or if she's had any complications. Then you can ask about these complications or red flags and things like that. Yeah, and then you can once you've extracted that information, I forgot to mention actually, not actually in the notes, is it, the past medical history and drug history? Yeah, that should be in there definitely. And allergies. Yeah, allergies is always a good one to fit in. But yeah, do your PMAF TOSA as well as this stuff here. Just pick and choose, obviously, the important stuff, so that you don't waste time. I would say, when you're doing this history, I would give myself to do the history. I would start explaining the procedure around the 3-minute mark. That's where I would want to start explaining the procedure. So I'd have done a quick history, quickly checked for blood thinners, past medical conditions, diet, and then move on to explaining the procedure. Potentially, you could ask about celiac disease, get an understanding about what she knows about the condition. If you've got time, but I wouldn't say it's essential. And then explaining the procedure. So generally for me, I when I'm explaining conditions or procedures or anything else, I do like to start off with what and why, and then I'll talk about how. So what is it that you want to do? Why do you want to do it? And how are you going to go about doing it? What does it involve? So that's just a very basic kind of structure, that makes sense to me. So what is it? Camera test, thin, long, flexible tube containing a small camera that's passed from the back of the mouth through the food pipe into the stomach and then into the beginning of the small bowel, and it's connected to a monitor that allows us to visualize the lining of the digestive system. And then why do you do it? To visualize and to take a sample. That's really important there. So it allows us to visualize and take a sample from the small bowel to be examined in the lab to confirm the diagnosis. So that's why we do it, to confirm the diagnosis. So if she's having questions about, or she's giving you questions about, why is this necessary, doctor? And I thought we already did a blood test. And you can explain that, that blood test isn't specific. And so this really is what we need, because at the end of the day, if she's going to be diagnosed with celiac disease, this is a life-changing diagnosis. it's going to have serious ramifications for her the rest of her life and her diet. And so it's worthwhile doing this procedure, even though it's, you know, a bit uncomfortable procedure, and it's not, it's a bit annoying for the patient, but at the end of the day, it's in her best interest that she, you know, gets this confirmed, because if she doesn't really, if a gluten-free diet isn't really found to be that effective, so she has the endoscopy, and then she repeats it after starting a gluten-free diet, and then there's still inflammation there, even though she's, you know, been having a gluten-free diet for 6 weeks, and then that tells you that there's not really much point in her starting a gluten-free diet. So it's really important for the patient in that respect. So the idea with the endoscopy is not to do it once, it's to do it twice. So she's going to do it once to check for inflammation, and then she'll do another endoscopy after having been commenced on a gluten-free diet for 6 weeks, and then she'll do another endoscopy to see if there's been an improvement. Because if there's not been an improvement, then that's kind of a refractory case, and so that's going to be managed completely different. So that's one thing to bear in mind as well. The reasons behind it isn't just to diagnose, but it's to inform whether or not starting a gluten-free diet is going to be of any use, if it's worthwhile or not. And then these questions all relate to kind of the how. So you should continue eating gluten for 6 weeks before the endoscopy is done, and then you'll be put on a gluten-free diet after that. You'll need to be fasting before the procedure for at least 6 hours. So solid foods, 6 hours, clear fluids for 2 hours. Clear fluids, by the way, isn't just water. That can include squash, black tea or coffee as well, are also considered clear fluids, but without milk. Fruit juice is not allowed. So yeah, so 6 hours foods, 2 hours clear fluids. So sedatives, so I'd call them conscious sedatives. So the patient's aware that they're not going to be asleep for them. They're just kind of relax them, make them a bit more comfortable with the procedure, and you know, it will make them a bit drowsy. So you need to warn them about that, you know, after the procedure's finished, they will need to be kept in the waiting room for a while to let the sedative wear off a little bit. You know, this will all be explained. I think it might be worth explaining it now. Actually, is the driving is that she should have somebody accompany her for the procedure, because if she's going to be taking the sedative, you know, she won't be able to drive home, so it'd be worthwhile bringing somebody along who can stay with her and then take her home, and then also, you know, be with her for the first 12 hours or so after the procedure, especially if she's been taking the sedative. She might not take a sedative. A lot of patients just will have the local anesthetic spray. And by the way, the recovery time in the waiting room afterwards, after the procedure, will differ according to whether they've had the sedative or not. I think it's 20 minutes. So 10 minutes if they don't have the sedation, and 30 minutes if they do. You know, before they go home. Yeah, it takes about 15 minutes really. So we talked about the risks. There, definitely important to include, you know, the risks. Definitely fit those in there. That's high leverage kind of information that you need to include in the sedation for these explaining a procedure or an operation or treatment. Definitely talk about the benefits, the reasons why you're doing it, and the risks. You know, make sure you've got that ingrained into your, like, as a habit. Explanation of benefits and risks of the procedure will be repeated on the day of the procedure when signing the consent form. So yeah, they'll come in on the morning of the procedure, and, you know, they'll give the final go ahead and sign the consent form. And by the way, you know, the patient can withdraw consent at any time, even, you know, as they enter the procedure room. Management, I mean, I personally wouldn't talk too much about this, to be honest. I would just mention about repeating the endoscopy again to see if the inflammation is resolved after they've been commenced on a gluten-free diet. I think these 2 points here are the most important thing, and maybe offer a leaflet, but I wouldn't talk about investigations really. There's not really enough time.